तो 70 attendees हैं, but I think there are still lot of people who are just writing not able to join. I think उन्होंने
now they can join. Now they can join. I don't think it. Sir, good afternoon. मैं डॉक्टर दिनेश मित्तल बोल रहा हूँ सर आईआईटी कॉलेज से। Okay, sir. Fine. Thank you, sir. Okay, sir.
हर्ष, जो लोग नॉट एबल टू ज्वाइन कर रहे हैं उनके अगर नंबर्स पे आप कांटेक्ट कर सको तो आप देख लो।
अभी तो कोई वो नहीं है, अभी भी आ रहे हैं लोगों के।
डॉक्टर भारत भूषण बार बार लिख रहे हैं।
यार उसको लिंक मैंने भेजा है।
नहीं कर पा रहे हैं अभी भी।
भारत भूषण बार बार लिख रहे हैं।
Good afternoon, sir.
Dinesh sir, good afternoon. Emma madam, good afternoon.
Hello, sir. Hello, sir. Welcome, sir.
Yes, madam. Yes, madam. Mamta madam, good afternoon, madam.
Good afternoon. I was just unmuting myself to wish you. How are you?
Yeah, fine, madam. Great.
Yeah, good. You all are doing a wonderful job of
With all your blessings, madam.
No. It is hard
Afternoon,
work.
sir.
Yes, sir. Good
Yes, sir.
afternoon.
Good afternoon.
Nitin sir, good afternoon.
Good afternoon, sir.
Yeah, good afternoon. Good afternoon. Shalini madam, good afternoon.
Good afternoon, sir.
Hi, Nitin.
Good afternoon, Dr. Nitin, sir.
Hello, Nitin sir. Good afternoon. Good to see you.
He is the evergreen hero.
Yes, madam. Absolutely, madam.
Raj?
Just a minute.
There's some problem with the link.
Manas,
Yes,
who's the admin? The support staff admin?
Sir, admin Mr. Harsh is there.
He's there now because you have to tell him at the end that he has to mute everyone else except the speaker. Otherwise, people keep on joining, the mics are on, then.
Yes, sir. Everybody will be muted. They are not allowed to speak. Nobody will be allowed to speak. Only the panelist will have the speaker.
Absolutely.
Even after the completion, they are not allowed to speak. They can only ask questions in the Q&A section.
Very good.
अभी सर ये हम भी पहली बार कर रहे हैं. हम भी we are also nervous about doing this.
नहीं हो जाएगा, बहुत अच्छा होगा. In fact, now with this success of DIP giving this and so many seminars now,
Yes,
with
sir.
almost an overdose, I would say.
Yes,
but
sir.
it is a death knell on the physical meetings.
Absolutely, sir.
So much of money, travel, stay, accommodation,
Yeah,
pharma money,
Yeah.
doctors money, everything. I mean, it's wonderful.
Everything is going to Zoom and WebEx and all these companies.
It's okay. I mean, it's still nothing. It's peanuts as compared to what we spend in physical meetings.
How many flight fares and whatever accommodation in 5-star hotels, all that will be reduced.
I don't even remember which is the way to the airport now.
Don't worry, it's the same for all of us.
I feel nervous to enter the airport now. Where is the gate number
Exactly.
1 and gate number 2?
Yeah,
It
exactly.
will change whole behavior of the people, sir.
Absolutely.
No,
But
going
still,
anywhere,
but you
going
miss-
anywhere out is a worry, now.
Yeah.
The
But
The
But-
most non-used word of 2020, most non-used word of 2020 is passport.
Oh my. See, but we do miss meeting people, you know, I mean,
Yeah,
interacting,
socializing.
going out, some small parties. That's
Yeah,
something which is a real taking a toll on the mental health.
exactly. Human being is a social animal, no?
Absolutely.
You need to meet people, interact.
I mean, simple things, no? Like suppose you have marriageable sons and daughters, you don't know how they can now meet each other, and
Exactly,
they are
exactly.
meeting on the road or something.
Tough times.
Sometimes.
But I believe Bharat Biotech has announced 15th August he is marketing the vaccine.
Ready market. This will be like this Sinopharma vaccine from China, which is already in use for Chinese military without a phase 3 trial.
Oh my God.
You have already used it, sir, Nitin sir?
Yeah, it's available for use of Chinese army, limited use for 1 year. And as usual, you know, the vaccine is smuggled and is available in Bangladesh.
Oh my God.
Easy. Came first in Bangladesh, then came to India.
How do you get all this news, Nitin?
No, this there are vaccine trackers.
मैं
You
कर
go
रहा
to.
हूँ मैं कर रहा हूँ मैं कर रहा हूँ I'm trying.
Sanju, I mean, see, because Bangladesh brought that cheaper generic whatever version of remdesivir, the prices crashed.
ऐसी बात करने का कोई नहीं है कोई भी हमारे पास कोई भी
Companies
आइडिया
which have brought remdesivir, they are competing with each other now. So it's
हमें
instead of
आइडिया ऐड करना
800, 4,200, 4,100, like that, you know. So you're talking about some 70, 80,000. It's come down to 20, 30,000.
Yeah.
Now tocilizumab not available. So itolizumab is there. Itolizumab is Indian company. It's third the cost. I'm sure if more use, they'll bring it down to even half. So like that, competition always helps
Yeah.
terminal user.
Yeah. More demand, more reduction in prices.
Hi Nitin, Dr.
Hey,
Manlani.
oh, how are you?
Hi, how are you,
Hello,
Dr.
sir. Good
Vasudev?
evening. Good afternoon.
So Anand looks the same. Have you put on weight or lost weight?
Hello, sir. Good afternoon.
वासुदेव का लाइन लिंक गया है.
Yeah, internet का some issues है.
You know, Nitin, it is like this. If you have a weighing machine at home which is not working, you are safest. You don't come to know you've lost.
But
if,
by and large, people
put
have
a-
lost weight. By and
Yeah, I
large.
think, yeah, because we have to do bartan jhadu pocha
See,
every day.
that
no?
and you eating
Good afternoon,
outside
Nava, sir.
food.
Good afternoon.
Outside food.
Yeah, that is important.
That also matters, yeah.
Basavaraj loses 100 grams every day because of webinars on the DI.
Food and without tea and coffee, homemade tea पीना पड़ता है.
दिनेश नमस्कार.
डॉक्टर वासुदेव आपका ऑडियो म्यूटेड है, उसको अनम्यूट करो तो आपका आवाज.
ओके, अच्छा ठीक है.
बात हो गई, ठीक है.
अब आ गया आवाज.
मैं पूछा कि आपका वजन कम हुआ कि बढ़ा है?
3 kgs
कि कम
loss.
हुआ? Loss, very good. अरे वाह वाह.
Good.
Very nice.
Homemade food.
Yes.
No
I think
outside
that
conference
eating
food.
healthy food that makes a
Healthy,
difference.
healthy
But
homemade
one
food.
thing, see, now almost since lockdown, none of us have fallen sick with
क्या आ
cough
रहे
or
हैं
fever.
मेल
Yeah,
डिफरेंट
yeah.
थी या क्या
It's okay, but otherwise, it's a very healthy season. Your
अटेंड उसको यू कैन डू ना तो
CRP will be
उसको
very
आप क्या
low.
करो उसमें
Your
अटेंडेंस के
cardiac
साथ
profile,
जाके
everything. People
you-
have stopped taking antihypertensives. So
Yeah,
much
yeah.
was the hidden stress of day-to-day life.
Stress, subconscious stress.
Driving and patience and so many things.
It has its advantages.
It's a leveler
Right.
actually. So people who had very
Exercise,
huge practice,
walking, mentally.
very low practice, both are at the same level now. सेंट्रल आईबी से और कौन आने वाला है? बसवराज जी, बकुल आ रहा है?
Bakul,
हाँ,
Bakul,
पीयूष
sir
भाई
आ
आगे, पीयूष भाई आगे.
is there.
Piyush is here.
Hello, Dr. Naab.
Hello, अच्छा.
Welcome, sir. Hello, Dr. Vasudev. Hello,
Hi,
Dr.
hi. Good afternoon.
Dr. Vasu.
Good afternoon, Dr. Nitin.
Oh,
Dr. Nitin नमस्कार. Dr. Nitin अच्छा हाँ है.
Hi everybody.
पीयूष भाई,
हाय नमस्कार। ये मेरा वीडियो नहीं इन्होंने ऑन किया।
ये आप कर दो।
आप खुद करोगे?
आई कांट डू
वीडियो ऊपर जाके ऑन कर दीजिए।
I can't do it. I think it is
क्यों?
disabled.
Just click on your photo and icon above will come, sir. Just click on your photo.
I don't know whether you can hear me.
डॉक्टर पीयूष,
Hello.
हाँ जी सर।
हाँ कैसे हो? बोला आपकी वीडियो नहीं चल
मैं
रही,
अच्छा
ऑडियो।
हूँ। आप
हाँ,
कैसे हो?
एकदम
पीयूष अपना फोटो पे क्लिक करो आप।
हाँ मैं कर रहा हूँ।
हाँ,
Hello.
कुछ होता है।
Hello. Can you hear me?
Hi
Yes, sir.
Anupam. Hi Anupam.
Hi Mamta. Hi Nitin.
अनुपम सर को
How
अरे
are you?
बहुत अच्छा लगा आपको देख के अनुपम भाई।
Yes, for a long
Yes,
time.
I was listening to Nitin's discourse on hypertension.
Oh my.
My dosage of antihypertensives have gone up because
Wow.
I'm living with my wife now. पहले तो निकल जाते थे,
तो
20
आपने
हो जाता।
आपने क्या बताया? आपकी बीवी की हाइपरटेंशन दवा बढ़ गई बोला है, क्या बताया?
नहीं, मेरी दवा बढ़ गई।
अच्छा अच्छा, आपकी बढ़ गई, हम सोचा उनकी बढ़ गई।
मेरे को तो देख के उसको हाइपोटेंशन होती है। When she sees me at home, she goes into a shock.
Oh.
Sir,
So people here may not know one of the this one credentials to Piyush, that you should see on his YouTube his recital of poems,
नमस्कार।
महाभारत की poems. Very nice.
अरे वो लड़ाई वाली नहीं है यार, दूसरी भी है।
नहीं नहीं, लड़ाई की नहीं, अरे सबकी है, मैं कहा ना बोल रहा हूँ, लेकिन recital is important.
मेरा
That too with full
कैमरा
confidence.
नहीं चल रहा।
ये बकुल भाई, आपके आगे से लाइट बड़ी अच्छी आती है, क्या करते हो? इतना चमक आता है चेहरे पे आपके।
अरे भाई प्रेसिडेंट बन जाओ, प्रेसिडेंट बन जाओ, आपकी भी चमक आ जाएगी।
हाँ, उसमें हेलो आ जाती है।
ये
देखो बसवराज पे आधी तो आ ही गई है।
चमक है या कुछ खास चीज है?
डॉक्टर मधुल
I
खाने वाने में कुछ खास चीज मिल रही है?
नमस्कार जी।
think it's all about the lighting. If the light is in front of you, you are more bright looking. The back of you. बकुल ने तो एक स्टूडियो ही बना लिया अपने घर में, अभी इतना डीआईपी प्रोग्राम रोज होता है, तो बोला एक
हाँ बिल्कुल, और लाइटिंग वाइटिंग अच्छा तरह से पूरा अरेंजमेंट लाइटिंग का कर रखा है
सब
बकुल।
सिटी कॉन, स्टेट कॉन, पेडिकॉन की वाट लगा दी डीआईपी ने।
Dr. Bakul told me yesterday that he is in Khandala.
Yeah, I am at Khandala.
नितिन सर, if there is any technical issues, we usually ask Dr. Bakul sir.
हाँ।
Very expert.
Bakul, this weekend the whole EB was supposed to be in Khandala 24, 25, 26 का.
Yes,
my phone was giving the message कि you should be in Khandala.
Yeah, so I am at Khandala already waiting for you all.
दिल जला रहे हो हमारा, दिल जला रहे हो। ठीक है,
आ जाओ इधर, चॉकलेट वॉलनट फज खाने के लिए आ जाओ।
हाँ, आने के टाइम लेके आना ऊपर का।
जरूर लेके आऊंगा।
पीयूष भाई का वीडियो ऑन नहीं हो रहा है क्या? हाँ, अब आ गया, अब आ गया।
लॉन्ग वेकेशन, बकुल लॉन्ग वेकेशन ले रहे हो खंडाला में?
कोरोना ने पूरा लॉन्ग वेकेशन दे ही दिया है ऑलरेडी।
नहीं, अच्छा, आई थिंक अपना फार्म हाउस भी। हाउ द रेन्स इन दैट एरिया, खंडाला एंड मुंबई?
Khandala is second highest rain in the country after Cherrapunji.
Oh, अच्छा, so it must be raining every day, almost every day.
Every day it rains, but not continuously, so you get some time to go out.
Delhi में तो for last 3 days it has been almost raining continuously. Since morning also, raining since morning today.
Very good. But unfortunately, this time the rains are mainly in the city. It has to rain in the catchment area, na? That's the problem.
It is already raining in catchment area, na?
Good. Chalo, another 2 minutes we should be doing live.
Yes, sir.
Shalini, unmute yourself. Shalini, unmute yourself.
I think Shalini is trying to sort out the technical part. Shalini and Dinesh are both working to sort out that issue.
Okay, no issues, no
Good
problem.
afternoon, sir.
Good
Good
afternoon.
afternoon. Am I audible?
Sir, rate of
Audible, but less visible. थोड़ा सा light आगे से बढ़ाइए अपनी.
Dr. Dinesh. Hello.
Hello, sir. Hello, Dr. Kaushal.
हाँ जी, how are you, sir? Rate of
Piyush ji आ गए. Nice.
rate of participants देख रहा हूँ sir. Joining of participants is going up like anything. 214 have joined.
अरे वाह, that is great.
214 ज्वाइन कर चुके हैं.
कितना 400 रजिस्ट्रेशन हुए ना?
400 plus are the total attendees.
Wow, wow.
How many have logged in?
And
217.
There was a token registration, right?
217.
Yes, sir.
Yes, sir.
Right,
It
sir.
was paid.
Wow.
444.
Affecting all three lines.
कुल भाई सुनिए, सब फ्री मत
Yes,
दीजिएगा आप जीआईपी में. 50 रुपया फी रख लो.
We have kept 200 rupees, sir.
200. Oh, I see. And they paid online.
Yeah.
Wow.
For our zonal wings, we are keeping 500 rupees.
It is more than 450 registration, sir. I think there is some problem with the login. So
Oh, is
our
it?
AV is working on it, and there will be almost 400 people.
Actually, I think the email that has been given for registration and people are trying to log in through a different email, that is creating a little bit of.
I did the same mistake.
Already 202 have logged in. It shows
222,
202
sir.
attendees.
2 to 4 now.
It is increasing every second.
Yeah.
So with the permission of Dr. Bakul sir or Dr. Piyush sir, can we start it now?
Yeah, please.
Answer affecting all three cell lines, platelet, RBC, and leukocytes.
Start.
1 minute. 1 minute. 229.
Hello.
Okay. Shall I start, sir?
Yeah. Start.
Okay. Good afternoon, everyone. Very, very warm welcome to our esteemed guests and delegates. Myself, Dr. Shalini Goyal, Secretary IAP Delhi, and I'm really honored to be the first to speak on this auspicious day. Hematocon is second of our sub-specialty meet this year, and it's a pleasure that approximately 500 people from all over India and some international location are also participating in this. This is probably a largest registration based meeting till today. I apologize for any technical error, though we have taken utmost care to avoid it. Still, if we have for that, and we have planned this academic fees basically for all the delegates, students, and practitioners, and I hope that all of us will be benefited by it. And I'm very, very thankful to our all dignified guests, especially Honorable Dr. Bakul Parikh. Sir, good afternoon once again. Dr. Piyush Gupta, sir. Dr. Basavraja, sir. Dr. Vasudev, Dr. Nav, Dr. Smita, Dr. Manish Gupta, Dr. Kaushal, Dr. Premde. Thank you so much for being here with us today. I'm really very much thankful to all to accept our invitation for today. Now, Dr. Manas Kalra, who is our course coordinator, he is a pediatric hematologist in Sir Gangaram Hospital, who has really worked hard to shape this conference in such a way to attract interest of all the practicing pediatricians and students. And I hope this conference would definitely improve our knowledge in our day-to-day practice. Now, without taking much of time, it's already taken so much, but now I would like to invite Dr. Dinesh Mittal, who is our very dynamic personality, very hardworking, and very supportive president of North Delhi IAP. Basically, he will now moderate further. Thank you so much.
Thank you so much, Dr. Shalini. It gives me immense pleasure to have our esteemed guest from all over India, and it is an honor to welcome.
Dinesh, you are not audible.
Okay.
Good evening, everyone, and congratulations. Dinesh, you are not audible well.
Now it is fine?
Yeah.
Yeah, better.
That is better.
Thank you, Dr. Shalini. It is fine now, audible?
It looks better, yeah. Smita Mishra here. Yeah.
It gives me immense pleasure to have our esteemed guests from all over India, and it is an honor to welcome you all for the web-based registration only and e-conference on the hematology, which is mainly focused on the general pediatric practitioner. I'm really delighted to have Dr. Bakul sir, Honorable President of Central IAP, Dr. Piyush Gupta sir, Honorable President-elect of CIAP, Dr. Basavaraja, Secretary General, CIAP, Dr. Vasudev, Vice President, North Zone, Dr. Harish Pemde sir, who is the Joint Secretary Liaison for the CIAP, Dr. GP Kaushal sir, Dr. Alok Bhandari and Dr. Devinder Gaba, who is the Delhi State Executive to CIAP. It's heartening to see Dr. R.K. Nab, President Delhi IAP, Dr. Lalit Mandirata, President-elect, Dr. Krishan Jani, Vice President, Dr. Smita Mishra, Secretary Delhi IAP, and Dr. Manish Gupta, Secretary-elect from Delhi IAP. It's my pleasure to have people from my dedicated and passionate team from the North Delhi IAP on stage. Let me introduce Dr. Arun Garg, who is Vice President, Dr. Shalini, as you already heard her, she's Secretary, Dr. Satpal Yadav, Finance Secretary, and Dr. Manas Kalra, who is also a course coordinator of this course, and also our esteemed Executive Board member. Dr. Hema Gupta is a dedicated member of our team. I am really thankful and lucky to have our honorable speaker, Dr. Nitin Shah, Dr. Anupam Sasdev, and panelists Dr. Jagdish Chandra, Dr. Mamta Miglani, and Dr. Jyoti Kotwal to spare their precious time for this event. As you all know, all these people are stalwarts in their field of the hemato-oncology and need no further introduction. I am really thankful to our dignified guests to accept our invitation, sir. In the last but not the least, I'm really thankful to all delegates to spare their precious time for this event. Now, without taking more time, I'd like to invite Dr. Bakul sir to say a few words.
So thank you, Dr. Dinesh Mittal and Dr. Salini, the President Secretary of North Delhi, for inviting me and giving me this honor to be on this platform with so many dignitaries on the dais. And I'm happy to see our dear friends, Dr. Nitin, Dr. Mamta Manglani, Dr. Anupam Saddev, and my EB colleagues, Piyush Gupta sir, Dr. Basavraj, and other EB members and others, and also Dr. Nab, the Delhi IAP president. So I'm very happy to say that HIMET has started successfully today, and for a new conference to be successful, you have to have some topics which are usually useful in day-to-day practice for general pediatrician. And you have selected a topic that is anemia, which is very common in day-to-day practice. And also you should have stalwarts talking on that. And we have for that Dr. Nitin Shah, who is known to everyone as a great speaker and great academician, Dr. Mamta Maglani, Dr. Jagdish Chandra, Dr. Jyoti, and so on. I'm sure this conference has to be successful with this type of selection of topics as well as speakers. So with these few words, I congratulate you for doing this e-HIMETCon, and I'm sure everybody will enjoy academics during these particular topics which are being discussed during this conference. Thank you very much for inviting me here again. Thank you very much.
Thank you, sir, for nice words. Now I invite Dr. Piyush Gupta to say something for us.
Thanks, Dinesh and Shalini, the entire North Delhi team. And as always, already I have stated that I consider, though I now reside in East Delhi, but half of my life I have been in North Delhi, being born in North Delhi also. So I consider myself first as a member of North Delhi, and I take pride in all its activities, especially when my dear friends Dinesh and Hema, my dear student, are doing it. I see a galaxy of speakers. Nitin Bhai is there, so Anupam is there, Dr. Jagdish Chandra, Dr. Mamta. So I am sure the delegates are going to have a wonderful time today. And the topic they've chosen, anemia, I think this is on the hit list of the government also, because before this corona thing started, I had a talk with Dr. Paul at Niti Aayog, and we were in fact planning a very big program on T3, strategy of anemia control in India for the next year. And unfortunately, last 3-4 months, we have not been able to make any progress because of the obvious reason. But we hope that we'll revive this and we embark on a very big nationwide program in consultation and in collaboration with Niti Aayog. And I'm sure this will pave a way. This e-hematocon will start will make a very good beginning. So I thank all the dignitaries present. Dinesh has already named them. Bakul Bhai, thank you so much for giving this opportunity, the platform, and as I always said, he has turned this adversity into the opportunities, and we are all very grateful to DIAP for giving all this platform. So I wish very huge success for the smooth conduct of this e-hematocon, and happy learning all my friends and dear delegates. Thank you very much.
Thank you, sir. Now I invite Honorable Secretary of CIAP, Dr. Basavaraja, sir.
Yeah, respected Honorable Visionary President Dr. Bakul Jayant Parikh, sir, the President-elect Dr. Piyush Gupta ji, and our North Zone Vice President Dr. Vasudev ji, and our Executive Board Member Dr. Alok Bandari, sir, Dr. Devendra Gaba, and GP Kaushal. First of all, let me congratulate the Delhi team led by Dr. Dinesh Mittal, North Delhi branch led by Dr. Dinesh Mittal, Dr. Shalini Goyal, Dr. Hema Mittal, in with the team of Delhi President Dr. Nabha sir and Dr. Smita Mishra, organizing this in a wonderful conference. So it is happy to hear more than almost nearly 500 people are registered for this conference. Within a galaxy of a speaker, with a course coordinator, Dr. Manas Kalra, and our past president, Dr. Nitin Shahji, and Dr. Hanupam sir, and our Yamato Hang chairperson, Dr. Mamta Manglani madam, and other all faculties who are going to be there for next 4 days in this e-hematocon. So I'm sure our delegates is going to be benefited out of this. Without taking much time, I wish this conference to be a great success and wish you happy learning. We wish you all the best for the conference.
Thank you, sir. Now, Deep Jyoti Par Brahm, Deep Jyoti Janardhanam, Deepo Haritu He Papam, Sandhya Deepi Namostute. Meaning, I fold my hands before the Lord, the maintainer of this creation, in the form of this light. I adore this light which destroys all the pains resulting from my omission and commission. With these words, I invite all the esteemed people to join us for the inauguration and lamp lighting. Dr. Bakul sir, Dr. Piyush sir, Dr. Basavaraja sir, please join us for the lamp lighting. So, with the gracious presence and with the hands of Dr. Bakul sir and Dr. Piyush sir, I want to inaugurate this e-hematocon. The lamp light.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
So that was a small inauguration ceremony. Now it's time to introduce our course coordinator. Although most of you know him very well, Dr. Manas Kalra is a pediatric hemato-oncologist. He did his fellowship of National Board of in Pediatric Hemato-Oncology from Sir Gangaram Hospital, and then went to the Children Hospital at Westmead, Sydney, to do a 3-year fellowship in the Pediatric Hemato-Oncology and bone marrow transplantation. He's working as a senior consultant in Sir Gangaram Hospital, New Delhi, and he's young and dynamic physician with an immense academic interest and committed to the cause of teaching. Dr. Manas holds many important professional roles as well as is a known figure in the Indian Pediatric Hemato-Oncology Circle. He's the man behind designing the course and will moderate it for the next 4 days. I hand over the stage to him for the further proceedings.
Thank you, Dr. Dinesh. To have a registration of 450 pediatricians to a web-based hematology training course, I must say it is simply overwhelming. A big thanks to IAP North Delhi for giving me this platform. Heartfelt gratitude to Dr. Bakul Parekh, Dr. Basavraj, Dr. Piyush Gupta, Central IAP, Delhi IAP, and IAP North Delhi. Dr. Anupam Sachdeva, PHO chapter IAP, and also my institution, Sir Gangaram Hospital. This is a 4-day training course. We have one didactic lecture every day, and this will be followed by a case-based discussion on essentials of pediatric hematology. We actually planned it as a conference in Crown Plaza, Delhi in July, but you all know that due to the reasons that are obvious, we are having a digital meeting. We have stalwarts of this field from across the nation who will be sharing their knowledge with us. We have a pre-test which has already been sent to the participants and a post-test as well. Please ask your questions in the Q&A section. We will try to answer as many as possible. I hope you enjoy the sessions and are able to adopt some of the teachings in your day-to-day practice. For the first session, I would like to invite a very senior pediatric hematology oncology faculty, Dr. Nitin Shah. He heads the pediatric department at Hinduja Hospital and also works as an honorary PHO, pediatric hematologist oncologist at Wadia Hospital. He held the prestigious post of president IAP in the year 2006 and is a guiding force for the PHO chapter IAP. Dr. Nitin Shah will be speaking on approach to anemia in children. And sir, you have 30 minutes for this presentation. Dr. Dinesh, if we can allow him to share his screen,
yes,
we can start the presentation on approach to anemia in children, which will be followed by a case-based discussion on anemia in children.
Okay, great. Thank you.
So you're able to share the screen?
No, it says host has disabled me.
Just a minute. Just a minute.
Hello.
I request all the panelists to please mute themselves.
Yeah, now I'm able to share. Okay. Okay, right. All right. So thank you, North Delhi IAP, as well as the organizer of eMetacon and my friend Manas for giving me this opportunity. And I'm happy that this will be followed by some case-based discussion on anemia. So which means what I will tell you how to approach, you will actually put into practically by applying those principles to solve those cases. So with that, I will start to say that it is so pathetic to see that from National Family Health Survey data one back in 1990s to the current data in year 2015-16, if you look at the prevalence of anemia, it is almost the same. There is 78.9% in 2005 in children up to 3 years. And mind you, these are the children who are in the growing brain age. And if they have iron deficiency at that time, then they will be in trouble. So also the pregnant women, important because if they are anemic, they will not give enough iron to their babies. And if I talk of Maharashtra, where I come from, I have some data for 2015-16, which shows that almost half the population, whether it's a small child or the mothers, are still anemic. And I think we need to do a lot. And I was happy to hear our President-elect, Dr. Gupta, saying that he had a talk with Dr. Paul, and I hope he takes up his iron deficiency in a big way, because that is really leading to trouble for a lot of children. So when you classify anemia, you classify it based on the etiology to understand why anemia happens. You classify them based on the severity, because then you know what treatment you need to take. And most important is the rate of onset. So suppose you drop from 12 to 7 in one day, like in a G6PD deficiency, you will be acutely breathless and sick. Whereas an iron deficiency may come with 2 grams walking to you, and child may be perfectly looking otherwise okay. So it is important to not only understand how severe it is, but how fast has that anemia developed, because that tells you you need to really take precedence of treatment, or you have enough luxury to wait for your diagnostic procedures to be done to target your therapy specifically. So roughly, you know, either RBCs are not produced, or they are destroyed, or they are lost because of hemorrhage. And acute is where there is a sudden drop, and chronic would be over a time, like in iron deficiency. Now, what is important to understand is when you have a child of anemia, these are the 4 things you must ask. A detailed history, which is very important. A head to toe examination, which is equally important because it will add to the value. And by and large, you have made up your mind as to what the cause of anemia is based on history and examination. Then you do certain screening laboratory tests. There are plethora of tests available for otherwise for anemia. If you do all of them, it's a waste of money and you will be really lost. So based on what you see on the screening laboratory test, then you will actually do a confirmatory laboratory test if required and treat the patient accordingly. So age of onset, like neonatal anemia, mainly will be because hemorrhage or hemolysis, whereas older age group like 6 months to 3 years, iron deficiency predominates. By 5 years, your inherited bone marrow failure syndromes come in way, and adolescents typically have a lot of megaloblastic anemia. History of infection and worms very important in the rural part of the country, because still it is so much common that it itself can lead to anemia. Then community, because there are certain inherent anemia which are more common in communities like Sindhi, Punjabi will have more of thalassemia, Parsis will have more of G6PD, eastern part of the country will have more of thalassemia E disease, and so on and so forth. Then accordingly, if it's X-linked, then a male child will be affected like in a G6PD deficiency, whereas if it's thalassemia, it could be either sex affected. Diet, I think that's important. Improper diet, especially weaning food, and continuing bottle feeding, and even to some extent prolonged breastfeeding beyond 18 to 24 months without adding supplemental diet, is the reason for having such a high prevalence of anemia. And there may be then history of pica because of the altered appetite. Child may eat things which are not supposed to be eaten. And lastly, when you don't have any cause, look at the drug history, and you may actually be surprised that there might be some drugs which are going on which can lead to a suppression of bone marrow. Now, most important is the physical examination. So look at the tongue. So you look for pallor, of course, you look for shining tongue, you look for angulocheilosis. All these are tell you that these are nutritional deficiency children, and they are more likely to have nutritional anemia. And look at the nails. Platiniaca and koiloniaca is so much talked about in the medical books, but they are rare in children. But if they are there, then they are pathognomonic of iron deficiency and really clinches the diagnosis. Don't miss the mild hyperpigmentation in the knuckle in the megaloblastic anemia, especially in adolescents, or a pitted nail or a dyskeratotic nail, which you may see occasionally in a patient with inherited bone marrow failure syndrome. Look at the face of the child to see for hemolytic faces, which will be typical bilateral, parietal, and frontal bossing, depressed bridge of nose, malar prominence, pallor, icterus, you have pot belly, short stature, and that's the typical child of thalassemia, which is poorly transfused. Fanconi's anemia, of course, will have a typical face with perioral hyperpigmentation. Then don't miss a child with hypothyroidism. So you may have shining tongue with pigmentation in the megaloblastic anemia. You may have a lead level. You may have gum hypertrophy in an AML child. All these are important. Platiniaca, koiloniaca are rare in children, but if you see, then it is clinching the diagnosis. Dyskeratotic nail, especially most of the nails are dyskeratotic in a patient with an pancytopenia, would clinch the diagnosis of dyskeratosis congenita, especially with profound mental subnormality. Don't miss this hyperpigmentation around the knuckles. Very typical dark pigmentation and a cutoff, very clear cutoff of the normal skin. And this dark pigmentation is around the knuckles, either of the hands or of the legs. And they also have associated bald tongue with loss of papillae. So this is typical of a megaloblastic anemia physical anomaly. You have a typical box-like face with thalassemia with depressed bridge of nose, a pot belly, huge liver, spleen. These are all the signs of congenital hemolytic anemia. When you have anemia with hepatosplenomegaly, infections are very common in our country. Malaria is still common. In fact, we are seeing a lot of malaria in Mumbai this year. But surprisingly, after many years, we are seeing malaria. At least few patients admitted with 5x complicated 5x malaria. Hepatitis is common in children who are not vaccinated. Kala Azar in the belt of Kala Azar. HIV, fortunately, has come down because of very strong PPTCT program. But still, we will occasionally see some child with HIV. Infiltrations like leukemia, lymphoma, hepatoblastoma, all of them will come hepatomegaly. Some of them will also have splenomegaly. When you don't find anything in a child who is born to a consanguineous marriage, think of a storage disorder like Gaucher's disease. There may be a primary liver disorder like cirrhosis. Inflammatory disorders like Sogia can come with hepatosplenomegaly, and of course, not to forget hemolytic anemia that we saw the picture in the last slide. So you may have congenital infections coming like this in a small baby. You may have thalassemia coming with huge liver, spleen, unless they are transfused well, and they will also have failure to thrive. Uh, any child with a huge liver and spleen, don't forget malaria, and you may be surprised the peripherals may be studded with malarial parasite. The child may hardly have any symptom. This is very typical also in congenital malaria, where the newborn doesn't have fever at all. All he has is pallor and liver and spleen, and the mother had actually malaria during pregnancy. Then of course we don't see it often now, but when many years back when I was working with Cyan, and also after that when I was president, we made the national program for pediatric HIV along with Dr. Mamta Mangalani, Tripti Pensi, and others. And we used to see a lot of children coming with unexplained hepatosplenomegaly. We carefully see there is some history of oral thrush, and you do their ELISA and it's positive, and they were all patients with HIV infection. Very fortunately, the incidence is coming down. Huge spleen, hardly any liver, or there may be some liver, and you do a bone marrow in such a child, and you see the typical Gauchers or the Niemann-Pick cell, and you know you are dealing with a storage disorder. One clue to the young people who are tuned up today as delegates, that sometimes you see an adolescent boy or a girl coming with very subtle neurological signs, and they have typically what you call vertical gaze palsy, a very little liver is splenic palpable. Sometimes even ultrasound may pick up splenomegaly, which you don't even see. And I'm fortunate I work with Dr. Brajesh Sudani in Hinduja Hospital, and he will refer many of these patients, and we do the marrow and it's full of Niemann-Picks. So Niemann-Picks comes in adolescence many times with subtle neurological sign, not much organomegaly, and they have this typical vertical gaze palsy. That was anemia with hepatosplenomegaly. You have anemia with lymphadenopathy, another group of disorder. Again, infections are common, so TB is still prevalent in our country. In fact, today only we discussed in Hinduja meeting a child who came with TBM and had bilateral mandibular lymph node which are missed. HIV, as I said, coming down, but can come with generalized lymphadenopathy. Brucella, EBV, CMV are the other rare causes. Infiltrations are more common. You see generalized lymphadenopathy, think of leukemia, lymphoma syndrome. In a small baby, there may be a localized lymph node with skin rash, hepatomegaly, some ear discharge. Don't miss Langerhans histiocytosis in such children. Neuroblastoma can come with lymphadenopathy. In an older child, Sogia, SLE are the other disorder. I remember one child having PUO, weight loss, and submandibular lymph node, and there was nothing else. And then we investigated the child, we couldn't find a cause. Ultimately, we did the biopsy, and the surgeon said it was actually not a lymph node, but the submandibular gland itself. And he took it out, and it was in fact, so it was because of the Sjogren's syndrome. So they get this Sjogren's syndrome, which typically comes with submandibular gland, which is itself looks like a lymph node. And an immune cause of lymphadenopathy, Kawasaki, is what we are seeing in past. Now we are seeing COVID-Saki, what is known as a new term. During COVID time, children come with PIMS like or the multi-inflammatory disorder. They can come with lymphadenopathy. Recently, we discharged a child with PIMS in a 13-year-old girl who came with the right submandibular lymph node, then went into have fever, came in a shock-like stage. The lymph node had disappeared, little chapped skin, and her antibody for COVID was positive, and she was like a toxic shock syndrome following COVID. So these are the, and of course, if you see massive lymph node, then you think of this sinus histiocytosis with massive lymphadenopathy syndrome. Once in a while, you'll see children coming with huge lymph node, 6 centimeter, 8 centimeter in size, and otherwise looking very normal and benign. So you have the generalized lymphadenopathy, strip the patient and see the testis size, and you may miss the leukemia there. HIV can come like this, and lymphoma with superior vena cava syndrome will come like this. Anemia with bleeding, you need to differentiate between sick looking, non-sick looking. Non-sick looking isolated thrombocytopenia with anemia is because of hemorrhage, and you think of ITP. In a small baby, newborn, coming otherwise healthy looking, hemorrhage with anemia, hemorrhage disease of newborn because of vitamin K deficiency. Sick looking child, different ball game. Bone marrow is involved. Most likely it will not be anemia alone. It will be bi or pancytopenia. So you'll have leukemia, aplastic anemia, lymphomas, etc. Some infection like dengue also can come with, they will come with polycythemia, not anemia, but if the blood, they can become anemic, and so on and so forth. This is a typical child with ITP, well-looking child, subconjugal hemorrhage. You do the marrow, it shows you increased megakaryocytes. You have a sick-looking child, curled up, high fever, petechiae purpura, anemic, and you do the marrow or the peripheral smear. It will show you either the blast, if they have organomegaly. If there are no organomegaly, it could be hypoplastic or aplastic anemia. And anemia with skeletal changes, another group of disorder. So you have hand-foot syndrome in a small child. Think of sickle cell disease, especially they have painful, tender swelling of the dorsum of the feet and the hand. And as with the age, it disappears. You have chronic leg ulcers in a child with anemia. Think of sickle cell disease or any other chronic hemolytic anemia. And you have a typical skeletal malformation. So you have a forearm which is bent, and you do an X-ray, doesn't show there is absence of radius. That's TER syndrome. The children have thrombocytopenia, and they may have bleeding with anemia. Fanconi's anemia, of course, is typical. Everyone knows. I'll show you some picture. And I showed you disc keratosis congenita, which has the typical nail changes. So they can come with a bifid thumb. They can come with absent thumb. They can come with a malformed thumb, malpositioned thumb. So this is absent thumb. This is a typical bifid. High arch palate. They have hyperpigmentation. They have absent kidney or a malpositioned kidney. All these are pictures suggestive of a patient with Fanconi's anemia. This is a typical TAR syndrome where the forearms are bent, and you look at the X-ray and it will show you the absence of radius. This is disc keratosis congenita that I showed you before. You can also have reticular dysgenesis coming with pancytopenia and a typical skin pigmentation over the trunk and the face. So that's as far as the physical exam is concerned. Now coming to laboratory aspect. Now remember, when you see the CBC, don't make a mistake of looking at the normals which are given in the report. They are the normals for adult. Very few labs are smart enough to give you age-dependent normals. So you should keep this type of chart which tells you hemoglobin right from newborn till adulthood, so that you don't misinterpret. Just to give an example, if you have 10 gram hemoglobin on day one, it is extremely sick child, and your 10 gram hemoglobin in a 1-year-old is just at all normal or mild anemia. So like that, all the changes. Major mistake, you have an MCV which is high in a 1-month-old child, don't jump into megaloblastic anemia because that's normal for that age. All right, so what are the screening tests you do? The CBC, which should include indices and RDW and a retic count. And now you have automated counter which also give you retic count along with the screening test. So you should ask for from a reliable place. Counters are reliable because they are reproducible. They can do number of tests in a day, and they are less dependent on the people who are doing it, provided these counters are checked every now and then with a normal being running every day in the morning. So they must be calibrated. Otherwise, they can give you completely wrong results. And I think the most important test out of all this is a peripheral smear. If you ask me one test to choose from this, I will choose a peripheral smear, which I will see myself, because that sometimes even clinches the diagnosis in what looks like a very difficult case of anemia. If you have a CBC without retic in an anemic child, is like having a barber without a knife. And I would say if you have a CBC without an RDW in an anemic child, then again, you will not make any much head or tail of that CBC. So these are typical CBC. Just don't look at the hemoglobin, look at the RBC series, look at the MCV, MCH, MCHC, then you look at the RBC histograms, look at the WBC. Most of the counters also give you automated differential count. Look at the platelet count, and if possible, if you have a platelet volume, and some counters also give you immature platelet fraction. Now all these are very important from our day-to-day practice. So A word about red cell distribution width is the coefficient of variation of the red cell volume distribution. So what I see as anisocytosis on peripheral smear is what the counter will show you as RDW. So this is important. You have low MCV and a high RDW is iron deficiency. You have a high MCV and high RDW, it's megaloblastic anemia. So otherwise speaking, your nutritional anemias come with high RDW. If it is low MCV is iron deficiency, high MCV is megaloblastic. Your other anemias come with normal RDW. So you have a normal RDW, but low MCV is thalassemia trait. Your normal RDW with high MCV is liver disorder or aplastic anemia. I think this is a rule of thumb which will help you solve 9 out of 10 CBCs that you will see in your day-to-day practice. Retic is not a simple retic. It needs supravital staining, a separate type of stain, and you count 500 cells and you normally have 1 to 2% retic. Remember, in an aplastic anemia, and for that matter, most of the anemia, you should correct the reticulocyte count that you have obtained for the hematocrit. So give you an example, if a hematocrit is 45, that's the normal hematocrit, your retic is the actual retic. But suppose your hematocrit is 25, which is half of 45, then your retic is a 1%, your actual retic is 0.5%, which is low. So don't go by just the retic that you see, but correct it for the hematocrit. You have high retic, which means marrow responding to the cause of anemia, hemolysis, hemorrhage as the cause. Your low retic, the marrow is not responding to the anemia. Your marrow disorders like aplastic anemia, leukemia are the cause of your anemia. Peripheral smear, very important, bedside, cost effective, easily available. You can see, train yourself, and in a minute you can diagnose. In fact, when I started practice and I used to do the my own smear, a child will come with pancytopenia, and suddenly you will see that there is some disturbance. Dr. Gar, can you mute your mic, please? Yeah, okay, thank you. So I was saying that when I started practice, child will come with PU, has moved from here to there, done a lot of tests, and I see little liver and spleen, and there is some low counts, and I do a smear in my clinic, and on the spot stain and see there are blasts. I say leukemia. Patient will run away from me, saying that ये डॉक्टर पागल है, इतना डॉक्टर घूम के आया, एक ब्लड टेस्ट खाली इधर से लिया और बोलता है leukemia है. So that is the effectiveness of a peripheral smear in actual day-to-day life. So let's see some smear. This is a normal setting, normochromic, normal lymphocyte, normal polymorph, and a normal looking platelet, which you see around 10 to 15 per high power field. This is microcytic hypochrome. You can see empty cells, iron deficiency, probably someone has started iron, so you're having mixed population. This is typical thalassemia, target cells, broken cells, presence of nuclear red cell. Is typical of a hemolytic anemia profile. This is what I call a friend, hypersegmented poly. If you see a single cell, a single W polymorph with 6 or more lobes, or if you see 5 cells with 5 lobes, it is very typical of a hypersegmented neutrophil, which is diagnostic of megaloblastic anemia. This is a small child, painful movement of the hand. You can see the swollen hand. You do the X-ray, moth-eaten appearance. Peripheral smear shows you sickle cell. Your diagnosis is made on peripheral smear. You have an anemic child, diarrhea. We see it less often now. Has developed oliguria, anuria, hepatosplenomegaly, some petechiae purpura, sick-looking, puffy child. Your CBC shows that the hemoglobin is low, retic is high, and the platelet count has fallen. And you do the smear, it shows there is hardly any platelet. There are some large cells suggestive of a macrocytosis, some polychromatophilic cell telling you retic is high, and you see this broken cell, helmet cell, dust-like cell. This is what you call microangiopathic hemolytic anemia, typical of HUS or TTP-like syndrome. A lot of target cells to think of hemoglobin C disease, your ovelocyte or a pencil-like cell, typically in a deficiency anemia, but you can also have hereditary ovelocytosis or hereditary somatocytosis, things which are very rare. A no healthy looking child, some spleen, hardly any liver. There is history of anemia in the family. Father needed gallbladder removal. Grandfather had always chronic ulcers on the leg. He has moved from pillar to the post to find out the cause of anemia. All you do is a smear and you show this microspherocytes and you make a diagnosis of congenital spherocytosis. So that easy it is to make diagnosis based on your peripheral smear. Now the last part, you classify anemia based on your indices into hypochromic microcytic. When the MCV is below 75 or below 80 is microcytic, and MCH below 28 or 29 is hypochromic. Typically iron deficient anemia, but there are other causes. Normocytic normochromic, where the MCV is between 75 to 80 to up to 95. You have macrocytic anemia when the MCV is above 95, some take it 100. And there are various causes of microcytic hypochromic, normocytic, and macrocytic. So this is the microcytic hypochromic anemia approach. You can either treat them with iron if they are fitting into iron deficiency clinically and see for iron response. If there is reticulocytosis at 1 week, hemoglobin rises by 1 to 2 gram at 1 month and become normal by 3 months, you don't have to really do fancy iron tests. But in an older child, atypical presentation, you can do either serum iron TIBC on empty stomach, or better to do ferritin if there is no associated fever. And then based on what you see, you can classify them into either iron deficiency or thalassemia minor or sideroblastic anemia or anemia of chronic inflammation. These are the four. And congenital sideroblastic anemia is of course something rare, but you can pick up sometimes. So iron deficiency, hemoglobinopathy, especially thalassemia minor, anemia of chronic infection. Sometimes iron deficiency and anemia of chronic inflammation together in a child who is getting recurrent infection. Lead poisoning and sideroblastic anemia almost go hand in hand. A word about iron deficiency. During period of growth, poor diet, cranky child, bottle fed, having pica, associated with chronic bleeding of worms in an older child, will have low iron status, especially low ferritin, and a high RDW with low MCV is typically microcytic hypochromic iron deficiency child. You put them on iron and they will respond. Other way, if you're the older child, not fitting into iron deficiency history-wise, having good diet, suspicious because of community like Sindhi, Punjabi community, having microcytic hypochromic anemia with a normal RDW and a high RBC count is very typical of thalassemia minor. And then you have treated them with iron, but there is no response of any adequate response. And you see on a smear some polychromasia, some basophilic stippling, you know it is like some hemolytic anemia, and you can do straight electrophoresis and hemoglobin A2 will be high. A word of caution, sometimes if there is associated iron deficiency, like you see in some young women, pregnant women, age bearing child women, they may have thalassemia minor and associated iron deficiency. The A2 may be borderline normal. So you give them iron and repeat it and A2 will shoot up. So don't rule out thalassemia minor just because A2 is borderline in a patient where there may be a mix thalassemia minor with iron deficiency. Why is iron deficiency so common? And I think this is Dr. Piyush Gupta's next challenge when he becomes president next year. You have young mother who herself is iron deficient. As I showed you, 50% of them are. The child is born preterm, so there wasn't much time for the placental transfer. Was born of LSCA, so that little extra placental transfusion that should have occurred did not occur in a hurry. He's not being breastfed now. He's given cow's milk, which is poor in iron, is bottle fed and prolonged bottle feeding, so poor weaning diet, has recurrent infection with malabsorption, and has been given multivitamins by the general practitioner or the pediatrician, but not iron. And that is so sad that we prescribe multivitamin as tonics and not iron. And is not picked up in time, so his period of brain growth in the first 3 years is over. And now if you treat him with iron, his anemia will get corrected, but his cognitive function may never become normal. So this is a challenge, how to reduce this. And I think we'll have to start with both mother being treated and a child being given iron supplement as early as possible as per our national program. I will skip this slide. Enough to say no one salt. Give 3 to 5 mg per kg of elemental iron per day in 1 or 2 divided doses. I don't care you give on empty stomach. I don't care even if you give it night. So far as you give it in an iron deficient child and he takes it, he will improve. Deworming, iron prophylaxis to be continued, and if there is a rare case of true iron intolerance, then only give IV iron. This is the National Iron Plus Initiative, NIPI, NIPP. It says that 6 to 60 months, you need to give 20 milligrams of elemental iron bi-weekly throughout till 5 years. 5 to 10 years, you give 45 milligrams weekly throughout the year from 5 to 10 years. 10 to 19 years, you make it 100 milligram weekly throughout 10 to 19 years, and pregnant ladies and lactating women and women of reproductive age, 100 milligram. In pregnant ladies, you give it daily, and in age group of that, you give weekly. So you can see bi-weekly to weekly almost throughout your growing period. And I think this is something missing in our day-to-day practice. We must do it, and we can have a lot of iron deficiency being prevented. Macrocytic anemia could be megaloblastic. Typical is B12 deficiency, more common. Folate can be seen in older children. When you treat them, remember not to treat with folate alone, because that will correct the anemia, but it will worsen the CNS signs and symptoms. So you treat with both. When do you do test for pernicious anemia? If you have an adolescent with megaloblastic anemia, recurrent especially, not responding to oral B12, and has associated immune phenomena like alopecia, leukoderma, something, then you can investigate for pernicious anemia. Otherwise, 99 out of 100 or maybe 999 out of 1000 are going to be nutritional. Just treat them with initially injectable and then oral B12 folate. When you give to a very young baby B12 injectable, give it very low dose, especially malnourished babies who come with infant tremor syndrome, because if you give suddenly too much of B12, they may go into fatal hypokalemia. So this is the macrocytic anemia, hypersegmented poly. You see this polychromasia, basophilic stippling. You can see oval jolly body, and you do the marrow, it shows you the typical megaloblastic picture. You have non-megaloblastic macrocytic anemia, usually liver disorder, myelodysplasia, thyroid problem, lung problem, and so on and so forth. Rare, but you can see once in a while. I will just end with two cases. This is a 6-month-old child with low birth weight, prolonged jaundice at birth. He had diarrhea, for which he was admitted. He had pallor. The pediatrician saw that he's anemic. He just gave some iron and discharged the patient. Child did not improve. Came after 2 years with this picture. Now he's got stunted growth, the typical cretin look, and has got now mental retardation, which is not going to improve even when you start him on oral thyroxine. So hypothyroidism is a common cause of normocytic normochromic anemia, which you should not miss. And this child, older child, came with puffiness, pallor, and while walking used to feel breathless. His hemoglobin was 6 gram, which was normocytic normochromic. Retic was okay. All the tests were done repeatedly, were normal, but no one had taken his blood pressure, and he was treated with so many things. Took the blood pressure at 160 by 100. We did a creatinine is 3.5, and he is actually chronic renal failure. So remember, cretinism or hypothyroidism and renal failure are things which you can come only as anemia to start with, and not with other symptoms. And if you miss them, you will miss the bus. So normocytic normochromic anemia is not your cup of tea. You should refer them to the hematologist who will work up for hemolytic anemias, bone marrow disorder, and chronic systemic disorder to come to conclusion as to what the cause is. Don't waste time in giving them tons of iron, folate, and B12. Last story. The child was 3 years old. He was 3 gram hemoglobin, came walking. MC was 56, looked like iron deficiency. Was treated with 1 unit of Paxil and discharged. Came back after many years with weight loss, fever, diarrhea, oral thrush. And you know what we have done? We have given him iatrogenic HIV by giving that one single transfusion, which was not required for that iron deficiency child who was otherwise so stable and comfortable. So you will keep on hearing this transfusion mediated HIV transmission, and not only HIV, some other, even in rural part of India today, because of the unscrupulous blood bank who don't test them well or just give blood without testing. So with stringent criteria, lot of HIV which are transfusion mediated has gone. But I think it's not only HIV, it's also a lot of other side effect of blood transfusion which can happen, for which you should avoid any unnecessary transfusion. So blood is meant for the life to begin. Let not death begin. It's all here. What are the take-home message? When you see a CBC, interpret all the 3 cell line together. So you know it's single cell, 2 cell line, or 3 cell line down. So when you look at for anemic child, red cell indices and RDW are important. A red tick count is a must in every anemia child. A peripheral smear by an expert can be more important than hundreds of tests that you may do, bedside and cheap. Do not give steroids or blood transfusion without diagnosis, because you can mask a child of anemia who may be malignancy. and never feel shy in taking an opinion from an expert. Because if you take an opinion from an expert, you will lose that patient for that time being. He'll be diagnosed well, and the family will come back to you and will be thankful to you for referring them in time. Instead, you giving some haphazard treatment, patient going away from you, and now being diagnosed as a leukemia or something, that family will never come back to you. So when you refer, you never lose the family. In fact, you develop a better bonding with the family. Well, thank you very much for your patient hearing.
Thank you, sir, for a wonderful talk on approach to anemia. I think you have set the stage for us to now start with the case-based scenario, and you have taken exactly 30 minutes. So that thank you for that. And
Thank you.
Now sticking to our time and presenting our cases for the next 1 hour. Following this, we'll be doing all the question and answers that have been put in the live session. Some of the questions we are answering side by side, but we like to take some questions at the end.
Sure.
So is my screen visible?
Yes.
Yes, yes.
Okay. I would like to introduce the panelists for this session. We have very esteemed stalwarts of pediatric hematology oncology who will be giving answers to the questions that will be posed to them. First and foremost is Dr. Jagdish Chandra. Dr. Jagdish Chandra, as you all know, is Director Professor, Department of Pediatrics at the Lady Hardinge Medical College and the associated Kalavati Sharan Children's Hospital. The next is Dr. Mamta Manglani, who is the president of the PHO chapter. She is director at the Comprehensive Thalassemia Care Center at Borivali East, and she is also former professor and head at Sion, Mumbai. The next panelist is Dr. Jyoti Kotwal. Dr. Jyoti Kotwal is the head of the hematology at Sir Gangaram Hospital in Gripmar. It's really a pleasure to work with her, always very helpful. And ma'am will be giving us answers regarding the clinical, the lab aspects of anemia cases. So we'll begin with cases. I request the panelists to please unmute themselves. So the first case is, this case is for Dr. Jagdish Chandra. This is a 3-year-old girl who is a poor eater. She is bottle fed and she presents to the pediatrician for a routine checkup. She has pallor and the rest of the examination is normal. A CBC is done for this child and the CBC shows a hemoglobin of 6.5 gram %, a white cell count of 4,500, a platelet count of 5.2 lakh, and we know that we are dealing with a child with anemia. So my first question to you is, how do you classify anemia whenever a child with anemia comes to your clinic?
Good afternoon, Manas, ma'am, Dr. Mamta Manglani and Dr. Jyoti and everyone participating. Dr. Nitin Shah just gave a wonderful talk on how to approach to a child with anemia. And we all should remember that the hemoglobin normal values for children, they are not uniform. They are dependent on different age groups. There are different cutoff. Like for a child of this age, the cutoff of hemoglobin, which would be defined as abnormal, would be less than 11 grams. We should not have this impression that 10 gram is a good cutoff to define the low hemoglobin. No, it is 11, 11.5 between 5 to 11 years, and thereafter it is 12, and even in children, if we take adolescent boys, it is 13 grams or more is normal. So for this child, this age group children, the hemoglobin, any hemoglobin which is lesser than 11 grams is abnormal. It should be classified as anemia.
So this child, according to you, has severe anemia, a hemoglobin of 6.5.
This child, yes, if you go by severity, the hemoglobin less than 7 gram would be classified as severe anemia. So she is severely anemic.
The other forms of classifying anemias are based on MCV and RDW. So would you like to comment on that?
So this is when you describe the how to approach the child with anemia for a diagnosis. So there you take into account when you get the electronic cell counter report that is usually available these days along with the peripheral smear if you have asked for, and there you classify depending upon the presence of the microcytic, the cell size as well as the RDW. So based on that, we classify whether the RDW is normal or increased, or there is nothing like decreased RDW, but then cell size is normal, increased or decreased. So there could be various combination, MCV decreased with normal RDW or high RDW. Similarly, MCV which is normal and the RDW is increased or high, and MCV increased where the RDW is normal. So like MCV which is low and RDW is high, here the iron deficiency anemia and thalassemia, beta thalassemia major. These would be two conditions which would be prototype of this MCV low with RDW high.
So
Now, if we talk of MCV normal and RDW high, again here
help us to classify in microcytic, normocytic, and macrocytic anemia.
Yeah, that's right. Yeah.
And the further classification will be done with the help of RDW. The third way of classifying anemia can be based on the causes, where we will have decreased RBC production, we will have increased destruction, we can have blood loss, or we have decreased erythroid maturation and ineffective erythropoiesis, which can lead to a classification based on the causes of what is leading to anemia. So coming back to you, sir, this patient with a hemoglobin of 6.5, the RBC indices showed a MCV of 54, a RDW of 19, MCH and MCHC has also been given. What is your impression for this child with severe anemia?
So she is clearly having microcytic RBCs, and RDW is only mildly increased. I mean, just about on the higher side. And MCH, MCH is really low, but MCHC is just again borderline. So she has a microcytic hypochromic anemia with RDW just on the borderline, slightly on the higher side. So I would consider that there might be iron deficiency anemia alone, or maybe there is something else to it which is complicating the picture.
Thank you, sir. So as sir said that, we have a low MCV and a high RDW. The DDs are iron deficiency, thalassemia major, and probably we are looking at iron deficiency with that kind of a background. Sir, would you comment on how you interpret MCV on the bedside? Sometimes it is difficult for us to carry all the charts. And, we want to know whether this MCV is 54 is very obviously small, but, sometimes they are a little borderline. How do we do that?
So we know that for adults, we take a cutoff of 80. Generally, for children under 10 years of age, what we do is 70 plus age in years. That is the lower limit of the MCV, and upper limit as shown here, 84 plus 0.6 into age in years. So say for a 10-year-old child, the upper limit of MCV would be 90. 84 plus 0.6 into 10, that is 6 plus 84 is 90. And the lower limit would be say 70 plus 10, that would be 80 would be the less than 80 would be microcytosis and above 90 would be macrocytosis. So that is how we usually remember the MCVs for the children.
And for older children, you said that above 80 would be something that we will expect.
Yeah, for older children, 80 cutoff is fine. And actually for defining macrocytosis, most textbooks describe this formula, but generally for screening purpose, 90 is good because you would screen more and more children. but then one has to document what is the cause of hepatocytosis.
Yes. Jyoti ma'am, can you please tell us what we see in this picture? So this is the child that we are talking about. We did a CBC and a peripheral smear. We saw this image. Can you please describe to our audience what you feel this is?
Okay, this is a peripheral smear Romanowski stain, and you look at the size of the red cells as compared to the lymphocyte. So that 8 micron size, if it's smaller or larger, and that's how you call it microcytic. So we can see most of the red cells are smaller than the lymphocyte. So there is microcytosis. And then we look at hypochromia. Normally, a red cell has only 1/3 central pallor. So anything which is more than 1/3 the central pallor is hypochromia. And here you can see it's 2/3 to almost, this is a leptocyte which has been pointed, just the peripheral rim of the hemoglobin cytoplasm, and the rest is all empty. So there's microcytic and hypochromic change. And then we can see these few much smaller cells and these elliptical cells, which we also call the pencil cells. So there is microcytic hypochromic anemia with not severe anisopoikilocytosis, but my moderate anisopoikilocytosis. So along with this peripheral smear, if we look at the combination of the RDW, which is also called Bestman index, when we talk about thalassemia screening, as well as the total RBC count, we can say whether it's a pure iron deficiency anemia or maybe a thalassemia trait with concomitant iron deficiency anemia. So that's how one goes about reporting a peripheral smear along with the CBC.
So this is definitely microcytic hypochromic, ma'am. Thank you.
And with some anisopoikilocytosis.
With some anisopoikilocytosis. Ma'am, can you tell our fellow colleagues something more about RDW? What is this concept of RDW and how is it useful for us?
Yeah, this becomes important. Like doctor, it was mentioned that sometimes when you're getting a peripheral smear in government hospitals, then you get the printout. And otherwise it's just the report which goes, but in the private labs the CV is normally printed out, the RDW. But the issue is there are two types of RDW. Sometimes you'll get an RDW SD and sometimes you'll get the RDW CV percentage. Whatever was discussed by Dr. Shah and earlier, all those cutoffs, that Bestman index is RDW CV percentage and not RDW SD. Sometimes in a private lab report, you'll get the RDW SD, and that normal range for that is between 40 to 55, and you'll be thinking that the RDW is very high. So you should see it should be the coefficient of variation percentage which you evaluate and not the RDW standard deviation which is given in femtoliters. So in the adult, the RDW-SD is from 40 to 55, and in pediatrics, it is 38 to 46. So it's very important to look at the RDW. The RDW CV is basically 1 SD of the RDW divided by MCV. So that's how it is calculated, and that's what is used as a marker in all the subclassification of anemias, and not the SD.
So basically,
it can be elevated in
if
non-nutritional
you have a
anemias
high
and
RDW, it tells you that your cells are all over the place. You have some very small cells, you have some very large cells, and most of
you
the
have
time,
a large coefficient of variation of the sizes of the red cells.
yeah. So it tells you most of the times that either it is a nutritional anemia or it is a thalassemia major. We have to look at other parameters and then fit into our diagnosis. So coming back to our case, we thought that this is iron deficiency. Although I have withheld some information and not given you all the information, because whenever we look at the CBC, there are just so many things written in the CBC that we tend to look at 4 or 5 things and we make an impression. But we are trying to impress upon everyone that we have to look at each and every aspect of the CBC. So to confirm iron deficiency, sir, Dr. Jagdish Chandra, if you have to do one test, what test will you do? Sir, you are muted.
Sorry, where the dietary history is quite suggestive that this might be a nutritional deficiency. The only problem with the cell counter report is that the RDW is not fitting in too well with the just iron deficiency. Therefore, probably a test for documenting iron deficiency is important. And I would like to do a serum ferritin in this child. And otherwise, in most of the cases where a microcytic hypochromic anemia, which is with the history, it appears that nutrition deficiency could be there. The rest everything is fine with the CBC suggesting iron deficiency. One usually does start the therapy with iron, and improvement with iron therapy itself is confirmation of the diagnosis of iron deficiency anemia. But here I would like to do a ferritin, because I said there are some parameters which are not too well fitting in just with iron deficiency. So as you have shown, hemoglobin low, MCV low, RDW increased, iron decreased, ferritin is also decreased. These are the tests which are available, but they are, like say serum ferritin alone mostly suffice. And if the serum ferritin in a child where strongly it is suspected that it is iron deficiency, and serum ferritin is say 20, 25 or 30, 35, which may be because of associated infection, then in that case one needs to do this, the transferrin level as well as the percent saturation. So these are enough to diagnose the iron deficiency in these cases.
So as a single test, ferritin, and these
Yeah.
are additional tests that are available, but please look into the clinical picture whenever we have to diagnose. So we look at the same child, ferritin was low, and I just give you the information that we did not look at the RBC count initially. It was 5.5 million. Jyoti
Yeah, that's right.
Jyoti ma'am, what is your comment on the RBC count now?
It is increased for the age and now and for the MCV. So now if we take the combination, or even we can do the Menzel's index, that is TRBC, MCV by TRBC, it goes in favor of a thal trait with concomitant iron deficiency. And if I remember the first slide, you had given a high platelet count, which
That's right.
goes in
So
favor
it
of
was
iron.
5.2 lakh.
Yeah. So the whole red cell indices combination, that's RDW not being very high, total RBC count being on the little higher size, goes in favor of thal trait with iron deficiency. But as Sir said, my only first test at this juncture would be ferritin. If it's low, treat the iron deficiency and then look at the hemoglobin HPLC.
So we need to remember the rule of three, where RBC count times 3 generally gives the hemoglobin. Hemoglobin times 3 gives the pack cell volume. Not all, it does not always fit in, but in this case where the 5.5 million RBC count was there, the hemoglobin should have been more. So here hemoglobin is less, so probably there is too many red cells being produced. Maybe there is a thalassemia minor which is sitting inside, and nobody is denying the iron deficiency that is present in this patient. So the child was given iron, hemoglobin became 10.5, the MCV is still 60, very low, and the RBC count is 6.5 million. So as madam said, now once you have corrected the iron deficiency, you have treated iron, the next step would be to do a HPLC for this patient. Most likely this child has a thalassemia minor. If somebody is very, very keen, you can do the HPLC of the parents. One of them will be a thalassemia minor. And we can see that this HPLC is showing a HbA2, which is 4%. So clearly this child has a thalassemia minor along with iron deficiency anemia. Ma'am also described the Menzer index. So Menzer index is less than 13 in cases of thal minor. You can see the MCV divided by RBC count. Here the RBC count will be high, so the value will be less than 13. Whereas in iron deficiency, the RBC count will also be low, the MCV will also be low. So the Menzer index will be more than 13, and it will point towards iron deficiency. This is only used for patients with mild anemia and should not be used for patients with severe anemia. Ma'am, would you like to comment upon reticulocyte hemoglobin? You're doing this test very often now. We get a fancy report of RET HB for our patients. Can you just briefly tell our audience what is RET HB?
See, it all started as the CHR, which was validated on the Advia Siemens cell counters, and very expensive. But in India, we have now got it as reticulocyte hemoglobin equivalent, more commonly on the CSMEC cell counters, and it's not very expensive. So basically, it is telling you the hemoglobin content of the reticulocyte count, and it is not affected by acute inflammation. And it tells you, like, if you look at the red cell indices, it tells you what happened in the last 100 or 120 days, but this is telling you about the erythropoiesis in the last 2 to 3 days. So if the reticulocyte hemoglobin content is low, it means there has been less hemoglobinization of the red cells erythroid precursors in the last 3 to 5 days. And it's a very good predictor of functional iron deficiency as well as absolute iron deficiency. And they are cutoffs also because it's not affected by inflammation. So it's been found to be equivalent to doing the transferrin receptor values. So that is the advantage. And we have a special reticulocyte count in our hospital where we give the reticulocyte count, corrected reticulocyte count, absolute reticulocyte count, and reticulocyte hemoglobin equivalent, which helps the clinicians.
Ma'am, what is the cost of this test if somebody wants to get a
We have kept it at the same cost as the reticulocyte count.
Oh, so not very expensive. Thank
Same
you.
cost.
Thank you, ma'am. So we learned about iron deficiency, low MCV, high RDW, low RBC count. We learned about high RBC count in microcytic anemia points towards thalassemia minor, correct iron deficiency, and then do the HPLC, and that the Menzer index is helpful in mild anemia patients. Now we go to our next case. Mamta ma'am, this case is for you. This is a 9-month-old child who has poor feeding and fast breathing. This child has severe pallor and there is a hepatosplenomegaly, rather splenohepatomegaly in this patient. The hemoglobin is 4, the TLC is 32,000, and the platelet count is 1.8 lakh. So this child has come to your emergency department with these features, and the emergency physician has done a CBC which shows those parameters and the RBC indices which have been indicated in the slide. MCV of 56, RDW 33. What do you think the patient has?
So this is a 9-month-old child with splenohepatomegaly, first of all, with severe pallor and compromised breathing because of severe anemia. And he is also having low MCV with a very high RDW. Now, a patient with hepatosplenomegaly with a low MCV hypomicro with very high RDW, which is even beyond 30, generally a thalassemia or a hemoglobinopathy. Also, he has a 32,000 white cell count, which is not probably the true white cell count. It is probably nucleated RBCs increasing the white cell count. And the splenomegaly is probably causing a little low platelet count because of huge spleen being present. So looks like a hemoglobinopathy to me because the age is right. The parameters are fitting into that.
And if I show you this peripheral smear picture, ma'am,
This is
would you
classical.
like to comment on
Yeah.
this?
So this is classically the target cells present nucleated RBCs. Dr. Nitin Shah also showed similar smear with actually we generally call it a very bizarre looking smear, which has very dirty kind of appearance when you see under the microscope. It is micro hypo, but very often in the first time diagnosis, we also see macrocytosis because of relative folate depletion in our patients, especially in India. Abroad, they do not see, they see typically the congenital chronic hypochromic microcytic anemia. We do not see that picture. So nucleated RBCs and all the other features are typically fitting with hemoglobinopathy.
Of thalassemia. Thalassemia major would be your first diagnosis?
Yeah, it could be because the age is 9 months. Yes, you would first consider, and beta thalassemia is the commonest, so we would consider that.
The new terminology is TDT, which is transfusion dependent thalassemia. And that is what we all are thinking about in this picture. Ma'am, would you also like to comment on this smear, or is it almost the same or anything else it shows?
No, there is polychromasia here. So because there is polychromasia, this might be a milder version of the thalassemia. So what we call as NTDT, the non-transfusion dependent thalassemia, because they have to some extent good maturation of the red cell series in the bone marrow, and ineffective erythropoiesis is relatively lesser. So you see some reticulocytes being thrown out and maturing to that effect. And there is some peripheral hemolysis in these children. So sometimes if you do a bilirubin, they would be mildly icteric and they would have a little indirect bilirubin too. So this is, and more nucleated RBCs, as you can see.
Ma'am, how do you confirm the diagnosis of thalassemia major in this patient?
So obviously, if the patient is not transfused, doing an HPLC is a good way of confirming the diagnosis. And you can see here, hemoglobin F is sky high, 92%. It can range from anywhere between 20 to 100%. And you have Sometimes an A2 which may be high, but not necessarily.
So this is thalassemia major based
Yes,
on
I wouldn't call it major. I would just say thalassemia homozygous, because we do not define major, or rather now transfusion dependent or non-transfusion dependent is also defined only after a waiting period. If the patient drops below 7 grams, at least 2
based
weeks.
on the clinical criteria.
Yes, yes,
Sure.
and clinical criteria.
Sure. So this is just one tabular column showing how the HPLC values change. So at birth, a child is born with a 65 to 90% of HbF, an HbA of 20%, and a HbA2 of 0.32%. And as the child grows, the HbF is supposed to go down to less than 2% by 1 year. HbA goes up to 85% by 1 year, and HbA2 usually remains around 2.5 to 2.7% in a healthy adult. So, this kind of gives us an idea. And at any time point, whenever the child presents, we can look at this criteria and we can see whether, our values are fitting in or not. Although these are not sacrosanct, there is always a little bit of a variation. We have to look at the clinical picture, examination, CBC, peripheral smear, and correlate with all those things. And this is just for the audience a normal HPLC, how it looks like in a adult person. So, ma'am, if this child has already received blood in another hospital in Mumbai, and then this child presents to you, how do you make a diagnosis of thalassemia or TDT in this patient?
So today's times, we go for molecular diagnosis straight away and we can get the diagnosis for sure. But of course, it will take a while. Meanwhile, you manage the patient for whatever the anemia. And alternatively, you can do parental HPLC, and that would give you a clue, because the clinical scenario is so fitting with thalassemia homozygous that if you get in both parents a thalassemia minor status, then you would almost confirm that the diagnosis is thalassemia homozygous in this patient. If we have to repeat an HPLC, it will be difficult because this child is going to keep requiring regular transfusions. But if at all you want to repeat an HPLC to get one of the best possible results, then you do it just pre-transfusion, just before you transfuse the next time. But that also will still not give you the original picture, but it will give you a picture for diagnosing.
Sure. So, I've talked about the high white cell count, which was being read as, because of the nucleated WBC. So this is just an illustration of what happens actually. So the automated counter gives you a total white cell count, which is white cell plus the nucleated RBC, which is the hallmark of thalassemia. So suppose this value is 20,000. The hematologist looks at the peripheral smear and gives you that, per 100 WBC, there are 20 nucleated RBCs.
Right.
In such a situation, we need to, correct that WBC by using this simple unitary method that for 120 WBC, you have 100 WBCs. You have 120 WBC counted, there is 100 divided by 120. And for 20,000, you multiply this value by 20,000 and you can get the exact value, which in this case is somewhere around 16,000. Alternatively, you can remember this formula, which can help you to calculate the corrected WBC count. And, sometimes your nice lab hematologist like Dr. Jyoti will give you the corrected WBC count and will make you even more lazy by giving you the correct answer in the peripheral smear. Ma'am, this is another question for you. You were talking about thalassemia. So I thought the next question also we'll direct to you is a 2-year-old boy who presents with poor growth. He looks a little yellow. And this is what, people have been telling him that, he always looks a little yellow. He has pallor when you examined him. There is mild icterus, there is a spleen, and there is a liver. The child is otherwise okay. Somebody told him that he has a liver disease, started him on UDCA. And, a doctor somewhere wants to give him blood transfusion because his hemoglobin is very, very low at this age. And somehow this patient comes to you for a second opinion. You did a basic evaluation. The hemoglobin was 6.4. The total bilirubin was 2.3 with a direct component of 0.4. White cell again a little bit raised. Platelets again a little bit low. And the MCV shows low MCV with a high RDW. How is this child different from the this child, and what is your impression?
So, as we discussed earlier, that this is a child who has not dropped his hemoglobin too low to require a transfusion in the early years of his life. And he has been sustaining somewhere between 6 and 7. And therefore, it's all right for him to sustain, but he has got poor growth, as you mentioned. And he has a liver spleen palpable, which is a suggestion of extramedullary hematopoiesis. He also has similar picture, as you can see, that with a mild hyperbilirubinemia of the indirect variety, which is typical of a non-transfusion dependent thalassemia. And he also has a very high RDW. He has microcytosis. So all these features again fit with a non-transfusion dependent thalassemia or a double heterozygote of various hemoglobinopathies which manifest clinically. So you could have a hemoglobin E beta thalassemia, hemoglobin rather beta and delta beta thalassemia double heterozygote. Compound heterozygotes will also manifest in a similar fashion, or even a sickle thalassemia for that matter. But on a sickle thalassemia, you will obviously, you might see irreversibly sickle cells on the peripheral smear, which you're not seeing here. So this fits more with a NTDT type of a condition.
NTDT, where the previous one was TDT, where the child was requiring transfusion, and this is NTDT, purely diagnosed based on the clinical and the CBC. So how do you differentiate between TDT and NTDT?
So as we all know that first time when a patient comes to you, if his hemoglobin is less than 7, transfuse him, wait for a period of 2 weeks at least, and see if his hemoglobin is dropping below 7 grams again anytime beyond 2 weeks. And if he drops again below 7, you definitely classify him as a TDT and not an NTDT. Of course, now that cutoff of age of transfusion below 2 years is no longer suggested by the new guidelines of Thalassemia International Federation. So I would not really keep that also. And neither the HPLC would give you any great help in differentiating the two. So the main thing is if they have clinical features which are suggestive of severe hemolysis or severe ineffective erythropoiesis, such as severe hemolytic phases, pathological fractures, poor development growth rather, physical growth, then you would consider rather that this is a TDT patient. So TDT is not defined on basis of certain laboratory parameters alone, but it is also clinical parameters. If they are not doing well, they better go on transfusions and make them do well. Not like having stunted child at...
Important message here that people often think that, you know, if your HPLC is 75-80%, you are TDT. So that is not the case. If you are not requiring transfusion, you are growing well, you are a NTDT, or what was previously called a thalassemia intermedia.
Yeah.
So thank you, ma'am, for clearing that. So peripheral smear and HPLC are key to make a diagnosis. TDT and NTDT differ in their clinical presentation. Corrected WBC count is something that we all should know how to do. Retic count is generally not very raised in TDT and NTDT because of ineffective erythropoiesis. And making a diagnosis in post-transfusion setting is not very difficult. We just need to know what are the right investigations that we have to do.
So if I may, Manas, just tell you that in NTDT, retic will be higher than in TDT, though it may not be very high. But sometimes you get about 4%, 5% retic. But corrected is generally not very high. It is about 2%, 3%, not more than that.
In the next 5 minutes or so, we'll just look at the importance of HbA2 window. We'll just go through this quickly. We have looked at iron deficiency. We have looked at thalassemia minor, thalassemia major, and thalassemia intermedia. But if you have a raised HbA2, there can be more hemoglobinopathies that we may be dealing with. Especially important is to look at the origin of the patient. So if you have a HbA2 which is less than 40% but more than 10%, and a person is from Northeast origin, usually we have a HbE disease going on. And if you have a HbA2 which is more than 40% and the patient is of Punjabi origin, then we usually have a HbD Iran. So just have this in your mind that, you know, whenever you are seeing something going wrong with HbA2, these may be the other diseases that we are dealing with. We'll very quickly look at it. So the first case, Dr. Jagdish, this is for you, sir. This is a child with a 12-year-old child, 11.9 hemoglobin. The name looks like that he's probably from Northeast origin. MCV is 80, platelet WBC is okay, but you see a HbA2 of 32.1%. What is your impression, sir, here? Sir, you are muted.
So the HbA2 in cases with thalassemia syndromes usually remains, say, between 3.5 to 9.5 grams. Anything 10 or above is generally not just because of the HbA2. So this is probably we are dealing with HbE, and as you have yourself suggested that the child probably belongs to Northeast. So, and here we see that F is 0.8 and HbA is 61. So he appears to be a HbE trait, and hemoglobin is fairly all right. So it's a heterozygote HbE disease, status,
So
not disease rather.
like we showed that HbA2 is less than 40%. So most likely there is a minor HbE along with HbA, which is leading to HbAE phenomena. Mamta ma'am, the next one is for you, which is 10.7 hemoglobin. Again, it looks like that the child is from West Bengal by the name. There is a little bit of microcytosis here as well. But here the HbA2 is 91%. What is your impression here, ma'am?
So it is probably a homozygous hemoglobin E because he's got a very high HbE. Because there are actually three things which you must remember when it is a variant machine giving you the HPLC. Hemoglobin LEPR also comes on the same site because the mobility is same. Retention times are same for all these three: hemoglobin D Iran, hemoglobin E, and hemoglobin LEPR, along with hemoglobin E, A2. So, but LEPR is not that common in our country. We have a couple of cases seen, but those patients are not really in true Indian descendants. Therefore, you don't see it so much. This looks like a homozygous hemoglobin E.
HbE, as madam said. Ma'am, the next one is also for you. This is again a child from Northeast with a hemoglobin of 3.4 here. It is very severe anemia along with the MCV that is low. Here again, the HbA2 is 68.2%. What do you think, ma'am, this child has, and why this child has such severe anemia, whereas the previous child did not have that severe anemia?
So her F is high, if you can see, 28%, which is significantly high. Therefore, there is probably an element of beta thalassemia in her. So it is probably a compound heterozygote of beta thal with E. When it is pure hemoglobin E homozygous, they generally do not manifest significantly. But when you have a beta thal with hemoglobin E, some may manifest very severely, some may still manifest very mildly. So it is a very wide spectrum. And therefore, just by looking at the HPLC and the clinical scenario, you cannot really come to a conclusive diagnosis sometimes. Sometimes you need to do molecular tests to confirm in them whether they have any other associated alpha deletions or alpha chain issues.
So this child did have a HbE and beta thalassemia. So one of the parent had minor thalassemia, one parent had E thalassemia, and that is why the child had a severe form. Dr. Jyoti, this is the last one. Ma'am, can you tell us about this patient? This is a patient who is Punjabi in origin, 15-year-old male, 11.3 hemoglobin. And this child also has a high HbA2. So, ma'am, what is your impression in this case? And there is a lot of HbA as well. What do you think this child has?
This is most likely HBD Iran, because if you look at the HbA2, you also look at the retention time. And the retention time of D Iran is a little different from HbE. And the other issue is the value. And to confirm, and you look at the red cell indices, they're absolutely normal. And to confirm, you can do a the gold standard to confirmation would be doing a HB electrophoresis at alkaline, and it will move with HBD on the electrophoresis, not with A2. So that will be the confirmation that it is HBD Iran, or you can go in for the molecular, but generally one doesn't go in because it's generally asymptomatic. So if you do a confirmation with by electrophoresis, alkali gel electrophoresis, you'll confirm the diagnosis.
So we looked at some of these hemoglobinopathies which confuse us because of the HbA2 value. We now move on to the next case.
Dr. Manas,
yes, sir.
Can I make a small point before we move further?
Yes, sir.
This is regarding that child with the E beta double heterozygote. Here, actually, the child has come before 2 years of age, and hemoglobin is very low. But still, I think we should give him a chance and study whether the rate of fall of hemoglobin is really like TDT or he is anti-DT. These are the children who are wrongly, because of the maybe some infection has led to this sudden fall of hemoglobin. So I thought that it would be a good information for the viewers that we should not jump to the diagnosis that this is TDT, because a lot of E beta is anti-DT. Thank you.
Next one is for you, Jyoti ma'am. This is a 7-year-old boy who presents with lethargy, pallor from few months. He has a microcytic hypochromic anemia, not responding to iron. He has mild joint pains and mild fever. Hemoglobin was 8.5, MCV was 72.8, RDW was 15. His RBC count is 3.5. And these are all real case scenarios that we are presenting today. This child was referred for this anemia and all these joint pains that were going on. We did a ferritin, it was 280. And, the thought was whether this child has a leukemia, because there is joint pain, there is fever, there is anemia, and something wrong is going on with this patient. We did a bone marrow for this child to rule out a leukemia. And this was what was the image. How did you help us to make the diagnosis of this patient?
So we go back to the RBC, to the earlier presentation, it was an iron refractory anemia. So treated as iron deficiency being the commonest and having a low MCV. And here you can see that the iron stores are grossly increased. And the ferritin is high. We don't have the serum iron TIBC, but that would be, I think, on the lower side with a low TSAT. So this is typically anemia of chronic disease, chronic inflammation, or any other chronic disease. And it is here that the reticulocyte hemoglobin equivalent, which we were talking about, would help. The ret HE would be low. So that would, because that doesn't get affected by inflammation, whereas ferritin gets affected by inflammation and may not give the representation in patients with anemia of chronic inflammation.
So the moment this child's bone marrow was done, we got a call from the lab that this is not leukemia. Please go back and examine this child properly. There is something going on. Something else is going on. Go and take a blood pressure. Go and do a growth chart monitoring for this patient. You are missing the boat somewhere. And that is when, a KFT was done and the child had a creatinine of 2.2, an ultrasound which showed small contracted kidney. The child actually had a chronic renal failure, which presented to a hematologist with anemia and joint pains. So, this is the importance of growth monitoring, BP monitoring, and again, looking at the RBC indices very carefully, where, we can make a correct diagnosis. So anemia of chronic disease usually is a normocytic anemia. There can be hypochromia as well. The serum ferritin is usually high. So please remember, all microcytic anemias are not thalassemias or iron deficiency anemia. There can be anemia of chronic disease in that category also. And you can have all these other abnormalities that can tell you that probably you're dealing with an anemia of chronic disease. So this is a case for audience, just you can scratch your brains a little bit while we have put you to sleep by talking about all these difficult scenarios. This is a 2-year-old child who's been wheezing for the last few months. He was diagnosed with iron deficiency and is on iron for the last 6 to 8 months. So this child has been getting iron and presents with severe breathing difficulty to the emergency department. And this is the X-ray image, courtesy Dr. Dhiren, who shared this image with me. To my hematology eyes, the X-ray was looking quite all right, but he told me that no, there is a lot of ground glassing happening here. His hemoglobin was 5. The child's hemoglobin was 5. TLC was 27. Platelets was 5.8. Iron deficiency like picture, where there is low MCV, high RDW, low RBC count, and a high ESR. So that is the time, when we started thinking, what is wrong with this child leading to this refractory iron despite being given iron deficiency? The CT clearly showed that there was something going on in the chest. Actually, the diagnosis here was pulmonary hemosiderosis, idiopathic pulmonary hemosiderosis, where the child was having repeated bleeds into the lungs. And this was what was leading to an iron deficiency anemia. And this is after treatment with steroids, the child became better and the X-ray showed clearing. Other causes of microcytic anemias are lead poisoning, hookworm, celiac disease. Very commonly, we are diagnosing celiac disease in North India, especially. Children with IBD have refractory microcytic anemias, intestinal polyps from where the children can bleed. This is the last of the microcytic scenario. We are just not going to discuss too many of others. Microcytic is the biggest chunk in our presentation today. But this is a 2-year-old baby who presents with recurrent blood transfusion and developmental delay. The hemoglobin is 7, the MCV is low, and the RDW is high. So, Dr. Jagdish, this is for you. This is again looking like an iron deficiency, but there is a background of developmental delay and recurrent blood transfusions. This child has microcytic hypochromic, received iron, HPLC normal, serum iron is 130, transferrin saturation is 46, and ferritin is actually 287. So again, you know, one of those DDs where we keep thinking iron deficiency, but it is not iron deficiency. What comes to your mind when you see such a case?
So, the causes of microcytic hypochromic anemia like iron deficiency, thalassemia syndromes, lead poisoning, these are not the conditions which would be associated with developmental delay. The another group where the microcytic hypochromic anemia is there, that is sideroblastic anemia, and some forms of that could be associated with developmental delay. There are different types of sideroblastic anemia. Not all have developmental delay, but some of them. So this could be one possibility, and where the ferritin is also very high. So probably a bone marrow will give an answer, and as you have shown here, marrow showing ring sideroblast. So that is the likely. Yeah, we have to consider such conditions as well.
Yeah, this child did have a sideroblastic anemia, and high doses of pyridoxine were given, and there was remarkable improvement in the neurological symptom. Child is no more on blood transfusion and is doing okay. So microcytic anemia
Manas, can I just come in for a minute? Just want to tell people that, you know, when an iron deficiency like picture on the CBC does not get treated with iron, don't keep pushing iron. After about 2 to 3 weeks, if there is no response, then this a relook should be done at the various parameters. Further investigation should be done, because iron deficiency, we often say therapeutic trial is good enough with a CBC. We don't even ask for iron studies. So you may not even have a high iron like you had in this. And therefore, don't push the patient, because here you are actually, when there's developmental delay especially, you are actually allowing the child to worsen. So allow the child to get the benefit of a right diagnosis and treat him accordingly, and there'll be wonderful results sometimes. All the sideroblastics may not respond to pyridoxine, but some of them do respond beautifully.
Sure. Thank you, ma'am. So we'll do the next case very quickly, sir, because we are going to do this in detail in the next couple of days as well. This is a 14-year-old girl who presents with lethargy, poor appetite. She has pallor. She has mild jaundice. She has mild cough. So a little bit of an infection, you know, brought in the child to the hospital when you found that, you know, she was quite pale. She had no hepatosplenomegaly, and the hemoglobin was 4.2. The platelets were also on the lower side. In this case, the MCV was 123, the RBC was 0.9, RDW was 22. What is your impression, sir, in this case? So you are muted.
So this child clearly has macrocytic severe anemia, and the platelets are low, though I don't have the DLC here, but DLC is just about the lower limit of normal. So at least bicytopenia or pancytopenia with a macrocytic red cell morphology, one has to think of whether it is we are dealing with a B12 folate deficiency situation. So that would be the first diagnosis. Yeah, we could call it a megaloblastic.
Yeah.
So just Manas, the RDW is high. So that helps, you know, to say that this is not aplastic and this is megaloblastic. And also the retic is not significantly low, but corrected might come below 1%. So
yeah. That's right. So, you know, what are the next steps in investigating this patient? So, you know, we would like to do a peripheral smear, definitely, to look at the...
yeah, that's right.
status, we would like to do B12 folic acid. If the child is already on supplements, doing these tests are not good because, they immediately get changed. LDH will be high, bilirubin will be high because of ineffective erythropoiesis. Sir, would you like to comment on this PS?
So this is like Dr. Nitin also showed, this is one hyper-segmented polymer with some cells which are larger, and and the red cell precursor which is seen on the lower side of the smear is probably a late normoblast. So this looks like fitting in with the megaloblastic anemia.
Jyoti ma'am, would you like to comment on these images?
The first picture was showing macrovalocytes, and now here you can see basophilic stippling. Though there is some hypochromia, so there may be some dual deficiency, but you're seeing basophilic stippling, which is also a feature you will see in a peripheral smear of megaloblastic anemia. And basophilic stippling for the pediatricians, if a peripheral smear, there are 4 causes you have to look for: ineffective erythropoiesis, megaloblastic anemia, MDS, 5' nucleotidase deficiency, and lead poisoning. So just that's for the thing. And the lower one is just showing a Howell Jolly body, which you get in megaloblastic anemias at time, but not so many, but an occasional one, and a Cabot ring. So those are all the features of ineffective erythropoiesis, which you can see in the peripheral smear of a megaloblastic anemia.
And this is some finding that, we always talk about the
Yes.
hyperpigmented knuckles, and Dr. Nitin also mentioned that in children with B12 folic acid deficiency. Ma'am, would you like to do a bone marrow for every patient with B12 or folic acid deficiency?
Not today with the tests available. When we were undergraduates and doing our MDs, one of the indications for bone marrow aspirate was megaloblastic anemia. Today it is not. I think we would do the B12 and folic acid levels, give a therapeutic trial rather than going in for invasive procedure. But if a bone marrow has been done, then you will see certain features. That's all.
So these are some of the causes of macrocytic anemia, and we'll not go into the details of that. But some will show a megaloblastic marrow and some will not. And we are going to discuss that in the next couple of days when we discuss pancytopenia. Now we'll just shift gears. For the next 5-10 minutes, we'll be discussing a little bit different kind of a scenario. So Mamta ma'am, this is for you. This is a 4.5-year-old girl who presents with fever, abdominal pain, and yellowish discoloration of the eyes for the last 3 days. There is previous history of being evaluated for anemia and jaundice, and there is neonatal jaundice as well when the child required phototherapy. On examination, there is a spleen, there is a liver, there is pallor, there is icterus. Weight for height is adequate for age. So the doctor considers a differential of acute viral hepatitis, malaria, because these are definitely much more common entities than hematological problems in our country. He thinks that, we are probably dealing with these situations because there is fever, there is jaundice, there is anemia, and he starts evaluating this patient for that. And at that point, the patient family shows that there was also a CBC that was done in 2019, and this CBC done right now. So would you like to point out something important in these 2 CBCs?
Yeah, so before I go to CBC, I'll take a minute to talk of the clinical because there are many good pointers in this case. For example, if you didn't tell me about the history of neonatal jaundice and phototherapy, I would probably even consider sickle cell and spherocytosis and, chronic hemolytic anemias of different various enzymopathies, which may be not as commonly causing an acute intravascular hemolysis, but a chronic slow hemolysis. So, but because you gave that history of neonatal jaundice, my mind goes more to spherocytosis rather than to sickle. Yes, in this CBC, if you look at, there is anemia which is moderate in nature, and you have a normocytic anemia, nearly normocytic. One is 76, one is 84. But if you look at the MCHC, that's where the diagnosis lies. It is pretty high. And hyperchromia in a patient with jaundice, with anemia, with a small spleen palpable, small 3 centimeter spleen palpable, and with an indirect hyperbilirubinemia, which is significant now in the new report, later report. So this would definitely make me think of a hemolytic anemia, which is inherited type, and most common we see is spherocytosis.
So the consult was given to you, and madam did her magic. The first thing she went was she asked for a family history, and there was a family history of splenomegaly. And the father just said, yes, my spleen is large from beginning, and I also had jaundice in early childhood. So probably we know what the diagnosis is, and the peripheral smear did show spherocytes, and this is the hereditary spherocytosis scenario. The retic count was asked for, which was very, very high, and osmotic fragility was done, which confirmed the diagnosis of hereditary spherocytosis, and the child was managed accordingly. Ma'am, would you like to comment that what kind of hemolysis this is? Because I think it is important for our audience to know what are the different types of hemolysis, and how do we differentiate between extravascular and intravascular hemolysis?
Yeah, so as you have put up the chart already, it's very simple to know. In an intravascular hemolysis, it is so sudden and there is no time for the RBCs are broken within the vasculature, and therefore there's hemoglobinuria. So there'll be urine which is high colored or red colored or pink colored. Then in a extravascular, there'll be icterus probably, because it's an ongoing destruction in the spleen. And when the RBCs are destroyed in this reticuloendothelial system, then there is an opportunity for the hemoglobin to be converted to biliverdin and bilirubin, and that's how you get icterus. So, and you of course have certain parameters like the plasma hemoglobin being positive in an intravascular hemolysis. LDH may be high in both, though it will be very high in the intravascular hemolysis. You will have a haptoglobin which is low to absent, hemopexin which is high in an intravascular hemolysis, and urine hemosiderin because of the hemoglobin being present, whereas all those parameters you will not get in an extravascular hemolysis.
And we know that the causes of intravascular hemolysis are mainly like paroxysmal nocturnal hemoglobinuria, transfusion reactions, burns, TTP, PCH, autoimmune hemolytic anemia at times, whereas extravascular hemolysis is mainly seen with some things like hereditary spherocytosis, hypersplenism, autoimmune, like warm autoimmune hemolytic anemias, and those will mainly show extravascular hemolysis.
So intravascular, Manas, if I may just add, G6PD sometimes can be very significantly acute and severe, and it would be intravascular also. Also, additionally, there are some other enzymes, enzyme deficiencies, which can lead to intravascular hemolysis. One more thing which we must not forget is what we used to see in the past with malaria, which was severe, the black water fever. We had actually seen those cases. Today, we don't see that kind of significant intravascular hemolysis.
So, ma'am, while you're talking about G6PD, I've put this image in front of you. Dr. Jyoti, would you like to comment what this is?
These are bite cells, but you also see blister cells more commonly also on the peripheral smear. That's because of the oxidant injury. So most common cause is G6PD deficiency, but we've seen patients with some drug-induced oxidant injuries also getting these cells. And this is showing fragmented red cells or schistocytes, and now there are very specific guidelines of how to count the schistocytes by the International Society of Lab Hematology. And some cell counters now even give a FRC, fragmented red cell percentage. So that's for people to know.
So, sir, if you have seen this schistocytes in the peripheral smear in the patient that you are managing, and you also get a history of sudden onset anemia with thrombocytopenia and some renal dysfunction, what is the diagnosis that you will consider?
So this is hemolytic uremic syndrome, which is the diagnosis. And if it is a older child, maybe an adolescent with these findings, with some neurological problems as well, then TTP would be the other diagnosis. Yeah. So in a younger child, it would be the HUS would be the.
So in younger children, even congenital TTP, ADAMTS13 deficiency,
Okay,
once in a
right.
while. It is not common, as you rightly said,
Yes.
but sometimes you may have ADAMTS13 deficiency. We had a baby who was 4-month-old and came with these features. So rare condition, but one must be aware because it can be life-threatening.
So we looked at some of the causes of intravascular, extravascular hemolysis. We saw some images. We talked about reticulocyte count, which is an immature red cell. It lacks a nucleus, and the value is around 0.5 to 2% in adults and 2 to 6% in children. Usually, a reticulocyte has a higher MCV. If there are too many reticulocytes, we term it as a polychromatophilia. What we see, there is a special staining called as a supravital staining when we have to get the retic count. So you have to specially ask for it. It cannot be done just from the simple CBC. And we need to know that we have to calculate the corrected reticulocyte count. It is given in all the textbooks, but still I have highlighted one example. So if you have a child who is a 6-month-old child with a hemoglobin of 3 and a retic count of 1%. So if you look at the range may look okay, that 1% is fine, but 1% is not enough for this hemoglobin of 3. If a person has severe anemia, he should be producing too many retics to compensate for that. So you look at the hematocrit, you look at the expected hematocrit, and then calculate it, and then you'll get the real corrected reticulocyte count, which is clearly very, very low in this patient. And I won't go into details of that because we are again going to discuss this when we discuss pancytopenia. So this brings me to the last case of today's session, which is a 6-month-old baby who presents with marked pallor. Now, ma'am, this child has come to you in your hospital at Mumbai, and he is the first child born to a non-consanguineous marriage, completely well until few weeks prior. And the mother's nutrition is also okay, because a lot of young children who come to us, their mothers are iron deficient, mothers are B12 deficient, but here the mother looks all right. There is marked pallor, there is no lymph node, there is no organomegaly in this young child who is 6 months old. And these are some of the images of the child. He does not look very normal to me. And there was also some abnormality in his digits and his hands. And you investigated this patient. You found a hemoglobin of 6. You found a MCV of 97 and a RBC count of 1.2 million. Ma'am, would you like to comment on what is going on with this child and what is the likely diagnosis?
So in a child who is 6 months and has pallor, and mother is fine and the child's growth is fine, and the way he looks from his appearance with the box-like faces and thumb and digit anomalies, the inherited constitutional pure red cell aplasia is one of the conditions that we must keep in mind, with a high MCV, with anemia, with normal RDW, with low RBC count, and even a retic which is seemingly corrected is 0.5% nearly. So this would fit with pure red cell aplasia. Of course, one must not forget that transient erythroblastopenia of childhood should be kept in mind. Had this child not had the typical appearance and the anomalies that you showed. So if that was present, then I wouldn't even think of TEC. I would think of Diamond-Blackfan anemia straight away.
Sure. So the retic count was very low, and we did a HbF which was little higher, and the bone marrow did show markedly reduced red cell precursor. So this is the other spectrum of retic count. We saw the very high retic counts in our hemolytic anemias, and this is the other spectrum showing very low retic count in children who have a marrow dysfunction, and in this case it's a Diamond-Blackfan anemia. So we looked at nutritional anemia, iron deficiency. We looked at thalassemia, both TDT and NTDTs. We looked at some differentials of microcytic anemia. We briefly looked at megaloblastic, mainly the nutritional components. We looked at intravascular and extravascular hemolysis. And we also looked at hypoproliferative anemia. So this was the spectrum of anemias that we discussed in this case-based scenario today. I think the important message which you all must have got is that, just by doing simple investigations, a good clinical history, an examination, a good peripheral smear, a good friendly lab hematologist, and, you'll be able to get the answers for most of your clinical hematological cases that you see in your day-to-day practice. I would like to really thank our panelists, Professor Jagdish Chandra, Mamta ma'am,
Thank you.
ma'am, for participating.
Thank you.
So enthusiastic.
Thank you, Manas. Thank you, ma'am. Thank you, Dr. Jyoti.
Thank you, sir. Thank you, Dr.
And I hope it was useful for our audience who have very enthusiastically attended this meeting. There are almost 300 participants still present who are, actively watching us and listening to our questions and answers that have been given. Dinesh, if you are here.
So Manas, can I have 1 minute? I wish to thank Dr. Manas Kalra for inviting us to this very interesting hematocon organized by North Delhi IAP. I want to thank Dr. Mittal and Dr. Shalini for having us as panelists here for this session. It has been a wonderful time because not only when you speak and teach, you learn, but I learned from Dr. Jyoti quite a few things because naturally we are not that much into lab as she is. So thank you, Dr. Jyoti, for those, small tidbits that we learned today.
I also learned a lot from your clinical
Thank you.
experience.
Thank you.
It was a
Thank
It's
given.
you.
mutual.
Thank
Yeah,
you
thank you.
very
Thank you
much.
so much. Yeah, Manas.
Thank you, Dr. Manas. Thank you, ma'am.
Thank you.
Thank you.
Thanks a lot.
Thank you, Dr.
Thank you, all the speakers,
I
for
think
being here with us.
we have a
Yeah,
lot of
Dr. Manas.
questions, Dr. Shalini, and
Yes.
maybe what we can do is just take down these questions and try to respond them through
On.
the WhatsApp group or online, so that all the questions are answered. We have
Yeah.
just crossed, I think, 5-7 minutes from our presentation, so maybe we can try to answer them later.
Yeah.
What?
Thank you, Manas, and thank you all the panelists for the wonderful presentation, and thank you all the attendees also who kept here for till last. Thank you very much. Tomorrow also will be joining. The joining link will be somewhat different, and I really apologize for some glitches initially. Some of you could not join, and we will try to sort
Hello.
it out. Thank you.
Thank you, Dinesh. Thank you.
Uh-huh. Uh-huh.